talking about multi-drug resistant organisms, or MDROs, how to prepare and respond. And I think living in the COVID world has prepared us in a way, but I think it's also made us live in our world of COVID blinders, where that's the only thing that is going on. And MDROs are a huge, I call it more, it's like a silent threat, because a lot of people can have them on their skin, be colonized, have no signs and symptoms, but they're just spreading around like crazy. And so, I hate to think of it as the new COVID, but the way things are going as far as the laws and regulations with responding to MDROs, it's kind of headed that way. So I want to make sure we cover some of those things so that we're ready for it. And we're not, sidelined, like just surprised like we were with COVID. So these are basically the learning objectives. I want to talk a little bit about the burden of MDROs in nursing facilities. The primary MDR requiring, which are the MDROs that we really worry about. I want to talk about this tiered response for MDROs and why that is that we have a tiered response. And then really focus on, what are some lessons learned from COVID that are going to help us with MDRO response. And of course, just kind of big steps for, what your facility can do to prepare. Next slide, please. All right, so MDROs, they cause a huge impact as far as illnesses, deaths, and of course, a huge financial impact. So CDC did a report on multi-drug resistant organisms and the threats in 2019. So this is pre-COVID. And they estimated that 2.8 million Americans are infected with multi-drug resistant organisms, and about 35,000 die a year. And it costs about $4.6 billion per year to treat MDROs. So they of course have a huge impact. And nursing homes and long-term care facilities, they are at greatest risk. Now, of course, we see MDROs in the hospital setting, but of course, as you know, patients move in and out from facilities, hospitals, and one of the issues, as you well know, with nursing homes is that you don't have the infection control staff that a hospital has, as well as an antimicrobial stewardship. It's, you guys don't have the resources, and so that puts nursing homes at greatest risk, because these resources aren't as strong as in acute care facilities. And there's been several studies to show that colonization, so people who just have these organisms on their skins, in their nose, all over the place, but don't have any signs and symptoms, it's very widespread. And it goes undetected, of course, because people don't have signs and symptoms. And so that, of course, serves as a huge source of transmission, with these organisms. There was a very recent study that was done just last year looking at residents, and they sampled 50 residents from September 2016 to 2017. So this was just recently published, but it was done in 2016-17. And they did find that there was about a 50% prevalence of these residents that had MDROs per nursing home, and it ranged from 24 to 70%. And that 45% of residents harbored at least one MDRO, and they didn't have any previous history. I think lots of people think, oh, these are the patients that are flagged in our system, they've had an MDRO, but almost half had never had any previous history. And these are the top MDROs that they found. MRSA, not surprising, ESBL, which are extended spectrum beta-lactamase, Viri, Siri. These are, I won't go into the details of each organism, but these are organisms that you hear about pretty frequently. And we see this is what these residents had. And then they also looked at environmental contamination. So they swabbed areas throughout the facilities, and they found that for 74% of residence rooms had at least one organism or more, and 93% of the common areas did as well. That's, unlike, COVID, which, I think when COVID first came out, we're like, oh my gosh, is environmental contamination a big issue? With MDROs, it is a huge issue. That's a big difference, I think, compared to COVID. So they can be on surfaces for very long periods of time, and they are a major way of getting transmission from the environment to your hands to a person. All right, next slide, please. Okay, so as I mentioned, CDC did this report that it came out in 2019, pre-COVID, and they really were talking about that we have made some good progress in terms of antimicrobial resistance in the United States, that they found that there was 18% fewer deaths from antibiotic resistance overall compared to a report that was done in 2013, and 28% fewer deaths from antibiotic resistance in hospitals since 2013. So that was, a big, that was a nice improvement. And they talked about decreases by different types of infections. But nonetheless, they still put on their watch list 18 microbial threats. And they gauged them and they categorized them by urgent threats, serious threats, concerning, and then kind of watch list. And they determined that, where they were going to categorize these different organisms based on the clinical impact, economic impact, how many new cases they were seeing, the 10-year projection of new cases, transmissibility. So how, when they looked at outbreaks or other things, how often were you seeing a lot more transmission of those organisms? The availability of effective therapies, of course, and then barriers to prevention, which is very important because some of them have more barriers than others. And of these 18, 67% were healthcare associated antimicrobial threats. So the majority are things that you see in healthcare facilities. Next slide, please. And so, I think when they came out with the report in 2019, I was like, yeah, we're gaining it's progress. We're moving forward. This is great. And then blum, blum, blum. Of course, COVID happened, which ruined everything because, we think so much of COVID and we've been living in our COVID world that we forget about these other things going on. And COVID, it's a snowball effect. You have COVID, you have more patients, you have more people who are ill. You have to do, new things to them. And so different types of therapies. And so you see, actually, we've seen compared to 2019 and 2020, there was a large increase in general healthcare associated infections. And you could see that included, this is from hospital data, but of course, many things that you see in acute care, if you start seeing more infections in acute care, you're going to start seeing them as well in your residents. And I think concerning was this laboratory identified MRSA bacteremia, a 33.8% increase. So it was, there's a lot of things going on with COVID that we focus so much on COVID that I think we forgot about these other healthcare associated infections, including MDROs, that many times do cause these types of infections. So we're just going to see in the next few years what this really means. Again, the 2019 report said, yeah, we made some great progress. We're keeping an eye on organisms, but we'll have to see really the impact that COVID has made on MDROs. And unfortunately, I think it's going to be an increase because we focus so much on COVID. Next slide, please. Okay, so what are these multi-drug resistant organisms? So I didn't want to go through every single one of them, but I did put links on the slide. If you're like, hey, what is a VRE? What is a ESBL? So I put links on there, and it's not like a long summary, but if you click on the links, it gives you a quick CDC put like just a few lines to give you a summary for each organism. But as you can see on the right, the bacteria that was found in the study, they were all of serious and urgent threat and concern, right? So that was, these weren't just, these are things we're kind of keeping an eye on, or they were kind of concerning. These were urgent and serious. And on top of, kind of CDC categorizing these antimicrobial threats as urgent, serious, or concerning, they also have deemed a list on the left of certain organisms that they consider novel or targeted MDROs. Now, this is going to be important because we're going to talk about this tiered response. So this specific list on the left are the targeted and novel MDROs because CDC feels like, hey, when we have any of these organisms, the response, the type of prevention control measures that we're gonna have to, have a higher level of prevention measures. So you can see that list on the left. Next, please. Now, one of the things I wanted to emphasize here is that of all of these organisms, very few of them are actually required to be reported to the health department as individual cases. So having worked in the health department for a very long time, I will tell you that that was sometimes an issue because if they weren't reportable, then no one really kept track of them. And it wasn't until things had gotten really bad and you had an outbreak or a cluster that then it would be reported to the health department. And then at that point, resources could be given to a healthcare facility to help them stop this outbreak. And so there's not many. One of the recent ones, it just became reportable this year is Candida auris. And we talked a little bit about that in previous sessions, that there is currently an outbreak going on here in North Texas involving several facilities. It's been going on for, I think, 3 or 4 months now. And there hasn't been a single facility that has been cleared of C. aureus, meaning they haven't had cases in 2 or 3 weeks. So, this is one thing to stress about MDROs is that the response is pretty heavy. And of course, it can be very prolonged. And again, most of them are not reportable by law, but when you have outbreaks, that is. So I think sometimes because each individual case is reported, it's, nobody's really keeping as big of tabs as compared to like a COVID that, you have to track almost every case, right? Next slide, please. All right, so just some general principles, not surprising. What would you do for an MDRO outbreak response? It's pretty standard like you would with COVID, right? You're going to identify affected patients. You're going to ensure appropriate control measures are promptly implemented to contain further spread. You're going to determine if transmission and dissemination is occurring. And then you're going to characterize the organism or the mechanism in order to guide further response actions, patient management, and future response. So it's pretty, it's kind of like you do with COVID. That doesn't change. You're going to find those people. You're going to quickly put in prevention control measures. You're going to see if transmission has been occurring, and then you're going to say, okay, this something that's a little bit different here. So you're going to have to say, we really need to know specifically what is the mechanism of resistance, because some make it a little harder to get rid of because they can be resistant to many bacteria, or the way the bacteria share that a resistance amongst each other makes it even more difficult. All right, next slide. Okay, so I talked about this tiered response, and I have a link to a CDC document that they have a nice summary of the recommendations by response, but basically they fall into 3 main categories. So, and there's going to be tier 1, tier 2, and tier 3 organisms. Now, you saw in that previous list on the left, those organisms that are considered targeted MDROs. So basically they're going to say, CDC says, okay, we're going to kind of put these organisms, generally these are the organisms that are targeted, and they're going to go on 3 different tiers: tier 1, tier 2, and tier 3. Tier 1 are things that are very rarely identified in the United States. Okay, they're pan-resistant. Now that tier 1 is that is the highest level. Like, oh my gosh, you have this. It is going to be a lot of prevention control, a very high level response, intense, detailed response. Tier 2 is organisms or a mechanism it's not regularly found in your region, but it's definitely been seen in different places in the United States. And then tier 3 is something that's regularly found, but it's not endemic, meaning we don't have a constant level of it. Okay, in facilities, but you do find it. So tier 1 is the, oh my gosh, highest level. We're going to have to do everything we can to stop this. Where tier 3 is, we're going to do, we have to do certain things, and other things we may not be able to because of staff shortages or shortages in resources, but we're going to implement some, if not most of the measures. So then basically the prevention falls into three categories: healthcare investigation, contact investigation, and then infection control measures. Now, based on each tier, again, tier 1 means you're going to have to do everything here. Tier 2 is you're probably going to have to do most of the things listed here. And tier 3 is you're going to have to do a lot of these, but not everything here. So the first thing in terms of healthcare investigation is obviously you're going to have to look at what exposure the patient or the patients had before and after the culture, the positive culture. Now that seems easy, but the question is, how long do you go back? You know, weeks, months. Lots of times it could be a month. And so for some patients, for some people, going back a month in their healthcare and the different facilities they had contact with, that's a lot. So that's one thing to consider. The other section is contact investigation. So that's going to include screening of roommates and healthcare contacts, prospective and retrospective lab surveillance. So now you're going to have to go back and say, okay, well, we've got this, 1, 2, 3 cases. We need to go back and, we need to make sure that people are being tested, and we're going back at old labs and seeing, did people have this and we just weren't aware? Something fell, it was a gap, and it fell through through our surveillance, keeping track of it. Even potentially doing household contact screening, healthcare provider screening, environmental sampling, screening and admissions. So again, it's not per se that you have to do all of these things, but if you do have a tier 1 or tier 2 organism, then that is going to be everything on that list. That's a lot of work. You're definitely going to need the health department to help you with that, but it does take a lot of staff resources. And of course, there's a lot of explaining to do because there's a lot more sampling going on. The next is infection control measures, of course, transmission-based precautions, or we'll go through it, enhanced barrier precautions in addition to transmission-based precautions, a notification of providers and residents, clear communication of resident status with transferring facilities, and those infection control risk assessments, those checklists that the health department has gives you. They can come down and do it, or somebody has to come and do it and actually do observations. So that's basically what you're going to do. So that's it in a nutshell, but all of these things going on at the same time for prolonged periods of time. Again, when you think of a COVID outbreak, I think earlier on, we did see that would sometimes take weeks. I can guarantee you for an MDRO response, it's going to take a very long time, especially if, this is one of those seek and you shall find sort of situations. Once you have 1 or 2 or 3 cases, and now you're having to really screen and look for this, you're going to find a lot more in your facility. Because again, people could have these organisms and have no signs and symptoms, have, completely be colonized. And that could be a problem for transmission. Next slide, please. All right, so I wanted to talk a little bit about enhanced barrier precautions. So CDC pre-COVID really pushed this idea of, hey, we want nursing facilities to do enhanced barrier precautions, which basically meant that you were wearing PPE all the time. And nursing homes pushed back and said, that's not going to work. We can't be wearing PPE all the time. This is where people live. This is their homes. This is crazy to imagine healthcare providers wearing PPE and having PPE all the time. Of course, then COVID happened, and that became the reality, right? That's what everyone had to do. And so just know that, of course, when you're doing an MDR response, an outbreak response, that it is going to go to enhanced barrier precautions, which basically means you're going to be wearing gloves and gowns for what is considered high contact resident activity, which you could see is pretty much everything: dressing, bathing, transferring, providing hygiene, changing linens, changing briefs, or assisting with toileting, device care use, wound care. So you can imagine how much PPE you're going to have to go through if you're having an MDRO outbreak. And on top of your wearing your regular contact and transmission-based precautions, you're having to do this not just for those residents who have MDROs, but for all residents in the same wing, the same unit, with any indwelling devices, anybody who needs wound care. And again, this applies to those targeted novel MDROs. And again, based on the tier, which pretty much I'll tell you right now, for any tier, the health department is pretty much going to recommend this. Maybe some of the tier 3s, maybe not, but anything tier 1, tier 2, anything on that list for sure. So just keep that in mind. As I mentioned, one of the outbreaks we are having here in North Texas is C. aureus. And this is what all the facilities are having to do that are affected. Next slide, please. All right, so just some considerations. We just talked about enhanced barrier precautions, right? You see what it entails. This is going to be a lot of PPE use. So it's something you have to think about and start planning ahead. If we had an MDRO and we had to do this for weeks on end, are we going to have enough PPE? Now, obviously, I think COVID has prepared many of us for that, but it's something to consider. The staffing needs are going to be very intense. You saw the things that were recommended, especially if you have one of those targeted organisms, to do swabbing of people, to check to see if they're colonized, a lot of things that will need to be done. Transfer to and from facilities, that is so major. It's so important. Whenever I would work any of these cases, but even right now when we're seeing with the C. aureus outbreak here in North Texas, is that one of the biggest factors was transferring people in and out of facilities, from nursing homes to acute care to other nursing facilities, and people weren't aware of the status of that patient. And so they didn't implement any precautions. And so that aided transmission. Again, these people people could be colonized. They don't even have signs and symptoms, and people weren't aware, and they didn't implement those prevention control measures. And that really drove transmission. Again, a little bit more about that infection and colonization. A lot of people can have these, and the response is going to be the same whether they have an infection or they're colonized. They just have it on their skin. And then, the surveillance cultures are very different. I mean, I think during COVID, everyone hated getting their nair swabbed. Everybody didn't like getting the MP swab. It was very uncomfortable. Nobody liked it. But imagine having to say, okay, well, we're going to do your nairs, we're going to do your armpits, we're going to do your groin, and we're going to do a perirectal swab. People don't like that. Okay, especially if they're not sick and you're just like, hey, we're just going to see if you have these bacteria. That's a tough sell. Okay, people don't like that, but it's something that is going to be needed for this type of response. So that's something to start considering. This is a lot of swabbing in a lot of uncomfortable places, and that's a difficult conversation to have. Right, next slide, please. So one of the references that I provided was a really good qualitative study that they did when they asked several nursing home staff, administrators in Canada. They asked them, kind of what were some lessons learned from COVID. And, I read the article and I thought this was really actually perfect for any response. The things that they talked about that were strengths versus kind of gaps. This applies to any outbreak. I kind of wanted to go through, there's 8 things that really stood out during these interviews, these focus groups they had with nursing home staff and administrators, and things, again, that were best practices and things that were gaps. So the first had to do with early identification. Obviously, the best practice is high suspicion, low threshold. This applies, for MDROs as well as COVID, because, you want to make sure that it's not something that you think, oh, well, this isn't reportable, we don't have to really worry about it. You always want to think, if somebody's transferring in, did you get a transfer form? Did you, are you aware of their status? A gap was being overconfident in your preparedness. So I think that, again, still applies to MDROs, thinking, we've got this, but did you really educate and train and plan for this? The next is, the public health and interventions. Best practice was, of course, broad support for public health measures, understanding them and understanding the rationale behind them. Now, I know that can be very difficult to explain. But the gaps really were that any interventions requiring optimal staffing levels, so anything that said, hey, this is a public health measure, we have to do this, but, of course, it required a lot of staffing. And that was, if there was a lot of staffing required and you just didn't have the staff to do it, then how can they be done? So this was obviously a persistent, pre-existing sector-wide staffing shortage, because whenever you had to respond, it did take a lot of staff. And if there wasn't some plan or something in place to bring in external people, or to say, how are we going to deal with having to do all of this enhanced precautions and other things that we have to do during an outbreak, then this is going to always be a gap. Next slide, please. So this goes to the next point, additional support and external assistance. So one of the things that was mentioned as a best practice is for infection prevention control support for assessments, education, and training to frontline staff. So a lot of the facilities talked about how, having rapid all shift approach. There was, we weren't just focusing on the day shift or we were focusing on all shifts, and then bringing in people external to management to do the education and training. Of course, you have to have support from management, but not done by management. That helped because, especially was in a non-punitive way. So that increased morale, it decreased anxiety, and one of the gaps, of course, had to do with inconsistent advice and conflicting guidance. And so I think that this is where it's so important to make sure that, when you're bringing in external people, that there is, they'll talk about it in just a second, about this communication to make sure you do have, the management is aware of what is it that external people are saying. Are there any conflicts? Do we, we need to make sure everyone's on the same page before it's communicated out. So in staff training, internal supplemented with external and ongoing in nature was a strength. An integrative approach with other infection control risks. So not just, hey, this is COVID, but this is how this also prevents flu or norovirus. When people thought of it this way, and it wasn't just, hey, this is COVID, they thought about it in the other bigger picture of other organisms, there was better adherence. And again, focusing on that bigger picture, protecting residents, protecting themselves as far as staff. And of course, the gap was infrequent or lack of robust training. So anytime, staff would say, I feel like, there was more outbreaks or more issues whenever, one of the things that led to these outbreaks is that we didn't get a lot of training. Or if we did get training, it was more of a check off the box, like, yeah, okay, you got training. So that was one of the big gaps. Next slide, please. So PPE use and supply, this one of the strong points, best practices is centralized access and distribution, where one of the gaps was fear and inconsistent changing of guidelines, which kind of led to unnecessary increased use of PPE. So double masking, double gloving, especially for people who are not practicing bedside staff. That was, that kind of goes back again to the training. So that, used up a lot of PPE unnecessarily. Of course, workplace culture and organizational leadership and management. Best practices addressing and managing staff fears through education and training, role modeling, working along frontline staff. A lot of the frontline staff in these focus group mentioned that, for them, it went a long way whenever they had a management and leadership right next to them, helping them do the things that they were doing. Whereas, obviously a gap would be a top-down punitive management style, where it's like, hey, we're telling you what to do, and if you don't do it, there's going to be punishment. That lack of role modeling, that was a big gap. Next slide, please. Okay, so the next point is communication coordination. Obviously best practice is explicit, consistent, transparent, reliable communication. So having like a daily safety huddle, to ensure that there was consistent approaches, that there was clarifying questions to explain rationale, that really helped build trust. So staff really mentioned that, these daily huddles, that they went a long way. Again, it was clear if there was any conflicting information. It was addressed immediately, and everyone was tried to be on the same page, and that included staff and family members as well. And of course, the gap was limited communication options. So, not filtering it down to all staff. One of the big complaints of staff was that, hey, a certain one shift would get it, but not another shift, or a certain level of employee would get it, but it wouldn't filter all the way down. And then separate communication and lack of coordination with external partners, sort of a struggle between management and external public health partners, where maybe management didn't want public health to come in. They didn't want these external partners. And then so there wasn't very good communication coordination between those. And that, that conflict between those just created more issues between the management and external partners. And then last is staffing levels. Of course, the best practice is considerations and planning for external staff as needed. And then one of the big gaps that was mentioned by a lot of staff was overnight staff being limited. That was always a big limitation. And of course, during this response, even more, because it takes time to do so much of these prevention measures. And it's not something you just do during the day. So that overnight staff being limited was a big gap, and not addressing that. Next slide. All right, so it's just kind of next steps for facilities. Make sure you're reviewing the guidelines from CDC. I provided all of the guidelines and the references, but also for specific guidelines, I put them in the slides. So make sure that you are reviewing them, you're aware, and start thinking about it so you could train and educate your staff on this MDROs and the tiered response. And then please use the, of course, interfacility infection control transfer form. So make sure people are trained on how to use it, and to use it, they know how to do it, and that it's getting to the right person in a facility. This is probably the biggest gap, is people will use the form, but it goes to the wrong person in the facility. Is it getting to the right person? Is it getting to the infection preventionist, or is it getting to the right person who is going to make sure that if somebody does have an MDRO, that prevention, that those transmission-based precautions are going to be put into place for that patient. And as you saw in those kind of best practices and gaps in relation to COVID, this of course applies to MDROs. And again, as I mentioned, this would be, even more of an extended response than COVID. That public health partnerships, that really is a must, because they're going to have a lot of resources, lab resources, and other resources that are going to be very important to be able to do, to be able to respond when there is an MDRO. Next slide. So the key points, obviously, MDROs are a major cause of morbidity and mortality in nursing facilities, long-term care, and there is going to be increased requirements and regulations related to MDROs, without a doubt. And these outbreaks can be very extensive. They're very difficult to detect and prevent compared to COVID-19. But there are a lot of lessons that we learned from COVID-19 that I think can strengthen all outbreak response efforts. And especially when you think of it, not just as organism specific, but, transitioning from, we're just thinking of COVID, we're just thinking of MDROs.